Thank you very much for waiting. We would like to start the next session, to hear keynote speeches. I would like to present today's keynote presenters first. The first one is given by Dr. Jong De Jong, President of the World Veterinary Association, WOAH. And the second keynote is given by Dr. Mark Schipp, former president of WOAH, chair of World Veterinary Association One Health Working Group. And the third keynote speech that is going to be given by Dr. Maria Minerva P. Calimag, President of the Confederation of Medical Associations in Asia and Oceania. Next, the chair of this session. Chair is Professor Tatsuji Nishihara, Fukuoka Prefecture One Health Education and Research Promotion Advisor and a Professor Emeritus of Kyushu Dental University. At the end of the three keynote lectures, we are going to have a session to have a general discussion, including the floor as well. And then we would like to have an interactive session, so that means all participants can ask questions to the speakers. And then when you look at the handout, you can find a QR code that is ready for each lecture, and you can ask or put the questions for that particular lecture. If you would like to just ask multiple questions, why don't you please just click the button to just send another question. And then you can start asking questions during the presentations. And then this is anonymous form. And I would like to hand over to Dr. Nishihara to proceed the meeting. Yes, thank you very much. I'm Nishihara. I would like to serve as the moderator of this particular session. Today, we are going to have presentations by three distinguished guests, and after that, we would like to have a session or have some time to make general discussion. So, what we can do or should do towards the realization, implementation for One Health for the future. And the first keynote is going to be given by a professor or Dr. Jong De Jong. And Dr. Jong De Jong began his career as a small animal veterinarian in Boston, Massachusetts, and specializing in surgery, and has held various positions in veterinary organizations, including president of the Massachusetts, New England region, and American Veterinary Medical Association. In April 2024, he was appointed the president of the World Veterinary Association and as the leader of an international organization representing veterinarians around the world. He has been addressing various issues in veterinary medicine, including One Health. And today, Dr. De Jong will talk about One Health. Veterinary medicine leads the way. Time to change from practical approach to accepted practice. So, Dr. Jong De Jong, now the floor is yours.
Konnichiwa. Greetings, colleagues and friends, Chairman Nishihara, and distinguished guests. My name is Dr. Jong De Jong. I'm the president of the World Veterinary Association, as you've just heard, and it is my pleasure and my honor to be here with you today. I'm a small animal practitioner from Boston, Massachusetts, yes, the home of the Red Sox. And not only is this my first trip to Fukuoka, it's my first trip to Japan. I've enjoyed my time here with opportunities to visit Tochoji Temple, Fukuoka Tower, to walk the streets, eat famous Hakata tonkotsu soup, cruise the Yanagawa River, eat the Yanagawa famous eel, pick and eat the Amao strawberries, which were the best strawberries I've ever had in my life, and be blessed at the Daizafu Tenmangu Shrine. I got to eat wonderful sushi, visit One Health operations at the Taro Group and Bridgestone, learn a great deal, but most of all, make many new friends. I commend my friend, Dr. Isao Kurauchi, who cannot be here with us this afternoon, and all of the individuals involved in hosting this One Health International Forum in Fukuoka, now in its 5th year. It is hard work that takes dedication, passion, and wisdom to develop the forum, but also to lead in the efforts to, as this year's theme says, opening up our prosperous future through One Health. I would like to begin my presentation with some slides that I had our Secretariat prepare for you to learn more about the World Veterinary Association, also known as the WVA. Before you is our mission to provide global leadership for the veterinary profession, promoting animal health and welfare and public health through advocacy, education, and partnership. Our vision to be recognized and respected as the trusted and influential voice of global veterinary medicine. And it works through 4 main objectives. And before you see our strategic plan from 2020 to 2025. We are currently undergoing a revision and developing our next strategic plan from 2025 to 2030. And as you see, they are animal welfare, pharmaceutical stewardship, now called medicine stewardship, we changed the name, veterinary education, and of course, why we're here today, One Health. Each objective is developed by a dedicated working group and chaired by a council member. And in the case of our One Health working group, our chair is Dr. Mark Schipp. So as I said, our strategic plan is under development. We have a council, and our council comprises the president, pres-elect, and the immediate past president. Our immediate past president, Rafael Legens, was here with you last year. And as you heard and know, Isao Kurauchi is our president-elect. And we have 14 elected representatives from different regions around the world, as well as international organizational members. Our committees and working groups comprise the council members and ad hoc members from outside the council that are nominated by our member associations to support and to strengthen the work and expertise of these groups. And our secretariat is responsible for the daily management of our association, communications, maintenance, and the development of membership. There's a photograph taken of our group when we were in The Hague in the Netherlands last fall as we met to talk about all the matters before the WVA. And you see our secretariat there. Our executive manager, Magda Lorenzo, is from Portugal, and our policy officer, Yvonne Nino, is from Spain. As far as One Health is concerned, I was able to represent the WVA at the World Health Summit last fall, calling for more involvement of veterinarians in more One Health initiatives. That's myself there with Dr. Tedros, who of course is the Secretary General of the WHO. And of course, World One Health Congress was held in Cape Town, South Africa, and we were represented by Dr. Mark Schipp, as you see there. And that was in September. One Health, everything on this slide speaks for itself. Global repository of guidelines for responsible use of antimicrobials in animal health. It's a global responsibility to be an AMU repository, and everything you see there speaks for itself. Easy access across the globe, and we do this based on surveying WOAH members and WVA members. Last spring, I got to speak at the United Nations about AMR and the importance of the role that veterinarians play in antimicrobial resistance. Veterinarians have been trained and know a lot about AMR and have for many years. We produced an essential veterinary medicines list for food-producing animals, our EVML. This was done in conjunction with the Brook, as you can see on that slide, and it follows the footprint of WHO's essential medicines list for human beings and adds on to WOAH, which is the World's Small Animal Veterinary Association, their essential medicines list for cats and dogs. Veterinary medicine is more than cats and dogs, as all of you know. Rabbits and poultry are going to be included this year. So, AMR, there's a triangulation of WHO aware classification, list of medically important antimicrobials, and a list of antimicrobial agents of veterinary importance. And this is to better inform national procurement of essential veterinary medicines, which sometimes can be a real challenge. I talked about being in the United Nations, and there's a slide of me at the UNGA, and it was pointing out the critical need for a One Health response, the accessibility for medicines, including vaccines. Vaccine research and development has dropped off quite a bit in the last few years. Strengthening of veterinary services, especially in some countries around the world that have trouble doing so, and the research and development of new veterinary medicines, which is so important for us to do what we do. And I talked about the EVML, our essential veterinary medicines list, and this follows the footprints, as I said, of the WHO. We give out scholarships to veterinary students around the world. It's a great undertaking. We had over 600 applicants this year. It's now under revision as far as how we go through the process, but it takes a large group of people to read a lot of applications of some very passionate young people that care about veterinary medicine, and we provide scholarships that some of them need so badly to be able to pursue their educational studies. The Veterinary Education Establishment Standards, this is a self-assessment tool, and the papers will be published shortly. I'll be going to Washington, D.C. in April to meet with CIVME, which is the American Association of Veterinary Medical Colleges international group, to talk about that and go from there. Animal welfare, recent position statements. Animal welfare, when I graduated from veterinary school in 1985, yes, I don't look that old, do I? But a long, long time ago, in 1985, animal welfare was a very small part of the profession, and now it's paramount in importance. And so we develop fact sheets and have position statements of various types regarding animal welfare of different species. And there you see farmed fish and aquatic animal health as examples. This summer, we are going to have our Congress in Washington, D.C. I'll talk more about that a little bit later. But we do have a One Health Summit, a full day dedicated to One Health there, as well as Animal Welfare and Veterinary Education Seminar, which will be for the first time ever combined, and for the first time in a couple of years, we're going to have a Medicine Stewardship Seminar. You can learn more about that at avma.org, events, AVMA Convention. And then, of course, you heard earlier, in 2026, we're going to be in Tokyo, and we're really looking forward to that. Japan, the JVMA, Japanese Veterinary Medical Association, put forward a wonderful bid and made us feel very, very welcome about coming back to Japan. And this is my first trip. I'm coming back in November for the site visit, and my whole family is begging me to bring them in April to Tokyo, and I plan on doing so. You can subscribe to our newsletter. There's a QR code you can look at if you want to subscribe to stay updated with what we do. We have monthly newsletters talking about all the different things that the WVA does on a regular basis. And as I said before, veterinary medicine, we're not just small animal medicine. You know, everybody thinks of veterinarians as the caretakers of your beloved pets. But we're also food safety, food animal production, research and education, epidemiology, public health, animal welfare, the human-animal bond, wildlife, exotics, aquaculture, and yes, One Health. The breadth and the depth of the noble profession of veterinary medicine needs to be better articulated and understood. And I implore veterinarians around the world all the time to be loud and proud about our profession and what we do. So I'd like to go over the abstract that I submitted. You have it in your program, but I think it bears repeating, and they give you some examples of some recent news that I received that really speaks to One Health in veterinary medicine. So the topic of One Health has been around for many years. Depending on the resource, it's safe to say that the concept began to take place in the early 2000s, and the first One Health office was established in 2009. And while the AMA, the American Medical Association, recommended the approach in 2007 for pandemic preparedness, in 2009, Dr. Lonnie King, a veterinarian, former dean at Ohio State University's veterinary school, and a good friend opened the One Health office at the CDC, the Centers for Disease Control in Atlanta. And the One Health Commission was also started as a nonprofit that same year. Another colleague and friend, Dr. Roger Marr, who was AVMA president from 2006 to 2007, introduced the AVMA and many of us to One Health during his term in office. And his vision was to increase collaboration between animal health, human health, and environmental health, the understanding today of what One Health is. It was the AVMA's One Health Initiative Task Force which led to the development of the One Health Commission in 2009 as well, led by Dr. Marr. In 2011, it moved to Iowa State University, and in 2014 moved to North Carolina with Dr. Cheryl Stroud as the executive director. And many other premier developments included the 2009 Canadian hosting of One World, One Health, and the 2010 Hanoi Declaration, recommending broad implementation of One Health. The 2010 creation of the tripartite between the WOAH, WHO, and FAO, and this led to today's quadripartite. In 2011, the first International One Health Congress was held in Melbourne, Australia, and here in Fukuoka, Japan, there have been annual One Health forums, as the one we're here today, since a few years ago, and today we celebrate the 5th forum. Of key significance is that veterinary medicine has always led the efforts to gain a further foothold globally towards the increased visibility and acceptance of One Health. Without veterinary leadership, and due to the real perception that much of the pushback, I hate to say it, to my medical colleagues in the room, has come from the human medical field, One Health would not be where it is today without veterinarians. But it's time for the veterinary profession to change One Health now, as I say in my title, from a practical approach to an accepted practice. So where do we do this? How do we go about this? Some of it's already been discussed today. Where does it begin? It would make sense to start through the educational processes at all the schools and at all levels. Interestingly, most veterinary schools around the world teach One Health as part of their curricula, yet many medical schools do not, especially in countries like the United States and bigger countries in Europe. It may be different in the Philippines. Maybe Dr. Calimag can talk about that. But luckily, this is changing, but far too slowly. There's also a seemingly large disparity between larger developed nations and lower and middle income countries. This was evident to me last fall when I traveled to the World Health Summit and the World Medical Association meetings. At the World Health Summit, the new director of a new WHO Academy acknowledged that veterinary medicine has long been the leader in One Health. And I publicly thanked him in front of the audience for his honest commentary, but I followed up by asking why there were so few veterinarians at their meeting in general. Luckily, I was applauded for asking the question, but I went on to say that if it was a World Health Summit, and not just a human health summit, you needed to have veterinarians there and people from environmental health as well. My closing words regarding One Health were that it was time to stop talking the talk, and it was time to walk the walk. And I can report to you the WVA, we've met with them several times in the last couple of months, and in all likelihood, we're going to be included in their program this October. At the World Medical Association, I spoke of increased collaboration between human medicine and veterinary medicine, and it was met with great support, mostly from smaller countries that are already practicing One Health, a lot of them here in Asia. For too long, there have been so many well-intentioned One Health organizations and projects around the world. And I'll get into that a little bit later too. As WVA president, I urge veterinarians to be loud and proud in speaking about our profession. And I ask all of us that believe in One Health to be loud and proud in speaking about the importance of One Health. If veterinarians can do so, we can be a more significant part of government and regulatory bodies, policy making, and the public can have a greater appreciation for all that veterinarians do. The veterinary profession must continue to be the leading voice for One Health. So some things that have just come out in the news. Example on One Health at the AVMA's printing on February 14th, just a few days ago. 3 veterinarians were unknowingly infected by H5N1, the bird flu, by antibody titers. 150 veterinarians were tested and 68 were confirmed to have H5N1 infections. Of those 3 that I mentioned before, they were unknowingly infected. 2 were not confirmed to have any exposure to animals at all that had bird flu, H5N1, and one was in a state in the United States with no infected cattle whatsoever. So it's out there. 968 herds of cattle in 16 states have been affected. And of the 150 veterinarians tested, 68 I mentioned were confirmed. 23 were due to exposure to poultry and 41 due to exposure to cattle. Rocky Mountain spotted fever, another article just came out in the last day or two about Rocky Mountain spotted fever affecting both animals, dogs primarily, and humans, and how they treat them, a lot of them with doxycycline. The problem is, who's seeing them? Well, the veterinarians are seeing the dogs, physicians are seeing the people, but we're not communicating with one another, and we really need to do so. If you think about it, your dog goes out and gets a tick in the backyard or outdoors, then they come into their house and that tick jumps off the dog and bites you. Now who's got Rocky Mountain spotted fever? So the reality is there are so many zoonotic diseases that are transmitted by various vectors, arthropod vectors, and other ways, other parasites as well. So as I said before, we need to appeal to the governments, regulatory bodies for increased visibility to change where we are from the practical approach to accepted practice. Egg shortages. In the United States right now, we are facing dramatic price increases in eggs. As an example, about 2.5 years ago, I paid 89 cents for a dozen eggs. I went last week, and now it's limited to 2 dozen per trip to the supermarket. You can't buy more than that because there's a shortage. And that 89-cent dozen is now $3.89. It's gone up that much, and they expect another 20% price increase in the next couple of weeks, or they say within the next month. At the World Medical Association, we talked about rabies. Every year, the World Medical Association, the World Veterinary Medical Association, we produce a public relations statement, a press release on rabies, because rabies is a very obvious viral disease that affects mammals, including humans, and it's often fatal. But we need to do more, and so we hope to have a renewed MOU with the WMA that we will sign later this year, hopefully at their meeting in Portugal, so that we can promote all that we do collaboratively in a One Health approach and articulate that. There's zoonotic diseases, there's parasitical diseases, and so much more. Just think about it. When you walk your dog, who's getting the good health out of walking your dog? Your dog is, but so are you, because you're getting fresh air and you're getting some exercise. So what to do to change from this practical approach to accepted practice? Educate the young. We heard these young people today. Last night, I met your superintendent of the Fukuoka Prefecture Board of Education. And here in Fukuoka, I applaud you. You are doing it right. You are setting an example. But this needs to be now spread to the other 46 prefectures in Japan. And from what I understand, it's not there yet. So Fukuoka needs to take the lead and show the rest of Japan. And that's step one. And then educate the people around the world, starting with the young. I know that Dr. Karauchi signed an MOU, for example, with Hawaii. Well, now, when he comes to Washington this summer for our Congress, hopefully we can expand that to other states beyond Hawaii, California, New York, Massachusetts, all of them, Florida. If we can do that and then get the federal government on board, we're taking huge steps towards getting to the reality where we need to be. Engage the governments, and that's what I just talked about. Hawaii is step one, other states step two, but now we got to go to Europe and Asia and every country around the world, get educational programs started in the schools. And what you've done here in Fukuoka is truly admirable, and you can take that message and put a stamp on the whole world about the importance of One Health. Enlist proper marketing. Well, it does take money, ladies and gentlemen. To make sure that we get a message out takes a lot of support. And so we have to ensure that the logo is well recognized, the logo for One Health. The term of One Health needs to be known to everybody of all age groups across the globe. And this will take time, effort, and capital. I think also it's incredibly important to coordinate efforts. We have to find a way to have all of the well-intentioned One Health organizations coordinate better at working together, because we can't work in silos. We can't all work in our own buckets. We need to share and communicate among prefectures, countries, and around the world. As an example, in November of last year, November 24th, 24, the One Health Commission in the United States put together a map. There are 605 One Health organizations around the world. I didn't know that until I went out to Google to find out. But the reality is, if there's 605, how many of them know a lot about the other ones? If they can coordinate their efforts and speak more as one voice, I think we'll go a long ways towards doing what we need to do. So with that, I'm opening this up to questions in a second. I first would like to say that I'm grateful for being here to Isao Kurauchi, my colleague and my friend. And I wanted to give him a little something. I came to realize not too long ago that really Isao Kurauchi, in my mind, is the champion of One Health. Not only in Fukuoka, but everywhere. So what better to give him than a NBA champion's Boston Celtics hat that he can wear because he is a champion. I look forward to returning in November for the site visit in preparation for our April 2026 World Veterinary Association Congress there. And I invite all of you interested to join us in Washington this summer for our 40th World Veterinary Congress hosted by the American Veterinary Medical Association. With that, arigato, and any questions, I'm here to answer them, and happy to be here.
Dr. John Delphon, thank you for your nice talk. But we have not enough time, so could you accept just one question? I got several questions from website. So just one question. Could you accept? Okay.
Of course.
In
Japan, the bird flu that have been taking place in Japan. And for this, in the United States, for this disease, what kind of measures taken in the United States? So that is the question. So this is a question for you. Well, it's been translated simultaneously. Professor, would you please answer this question? And also, during the comprehensive session, there are some other questions to be asked. So this is just one question that we'd like to ask you at this time.
Doing about avian influenza, H5N1 in the United States.
Yeah.
Primarily, it's isolation of various farms and poultry and cattle operations both, culling the animals so that you can limit the disease spread. If you're killing all those animals by humane methods, which is hopefully the only methods that are being used, and I think they are, that only is going to drive up the price of eggs, chickens, and beef. And so that's why it's so important to try and isolate, cull as necessary, and prevent further disease transmission. The other thing we have to be concerned with is it's the One Health issue. The people that are working on these animals are being exposed, and I just read a report actually this morning when I woke up of cats being infected by humans that were working with cattle on farms, all with bird flu H5N1. So it's a matter of isolating individuals, isolating cattle, isolating poultry, culling those animals that are diseased to prevent further transmission.
Okay, thank you very much. それでは次の演題に移らせていただきますが、その前に拍手でお礼の。
Well, thank you very much. And then why don't you please join me just to give you another round of applause. Thank you very much. Is Dr. Mark Schipp. I would like to introduce him a little bit.
Mark, Dr. Mark, can I introduce in Japanese? I'm sorry. Yeah. 次にご紹介いただきます。
So I would like to introduce Dr. Mark Schipp, the next speaker. In Australia, the chief of Australian Veterinary Association 12 years, and the WOAH, the president of this organization for 3 years. At the present moment, the Australian Veterinary Association, and then also he served as just a borderless, Physicians Association as well. And then she is the chair of a World Veterinary Association One Health Working Group, and he has been just tackling a lot of One Health related issues. Today, he is going to talk about One Health, translating a concept into practice, addressing global challenges for a sustainable future. So please just welcome Dr. Schipp.
Thank you very much, Dr. Nishihara, and thank you for the opportunity to speak to you on the important topic of translating the concept of One Health into practice. How do we implement One Health? We all acknowledge that it sounds like a good idea, but how do we bring it into practice? And are there any good examples? The world is facing many challenges, such as climate change, pandemics and food insecurity. Does the One Health approach offer solutions to these challenges, and how do we bring about a sustainable future? And is One Health something that is only relevant at the national and international levels, or is there potential for local communities to be contributing in meaningful ways? So let's have a look at that together. Firstly, I should define One Health, although the students did a very good job of that earlier today. According to the WHO, One Health is an integrated, unifying approach that aims to sustainably balance and optimise the health of people, humans, and animals and ecosystems. So there are a number of elements to this definition. One Health is integrated, so that means that we work collaboratively, we will communicate and we will coordinate our activities. One Health is unifying, so we will bring together expertise in human, animal and environmental health as a minimum. And the objective is to sustainably balance and optimise. So the objective is not to maximise human health at the expense of the environment, nor to focus on agricultural productivity at the expense of human, animal and environmental health. Each of the components, human, animal and environmental health, needs to be sustainably balanced and optimised. How do we translate this concept, this aspiration, into policy? And then how do we implement the policy so it is not merely words? Firstly, it's not so easy. There are many obstacles to the One Health approach, and here are some of those obstacles. Fragmentation and silos, one governance structures, research streams and funding follow established and traditional routes. Secondly, there is insufficient funding, particularly in low and middle income countries, so priority is given to immediate needs such as trade and health responses rather than longer-term investments in prevention and integrated health systems. There are technical capacity gaps also, both in expertise able to work across sectors and a lack of integrated surveillance data which is able to connect disruptions in the natural environment with animal health impacts and spillover into human health. There is resistance to change, and there are cultural barriers. Some people cannot or have not understood that their health is reliant upon a healthy environment and that we share the same pathogens as animals. There can be conflict between policy drivers where human health, agricultural productivity and environmental protection are at odds with each other. There is an issue of public and political awareness. The public are not familiar with the One Health concept, and politicians often have a short-term focus based on the election cycle rather than long-term planning. There can be an issue with international tensions. Some countries have lots of resources, but countries that have high risks due to animal populations, wildlife and human populations often have few resources. There's also an issue of tensions between countries, resulting in less cooperation and goodwill. Sharing data can be challenging. If it is health data, then people and countries are sensitive about how that data might be used. Similarly, data on disease that may affect trade. Even within a country, it can be difficult to share data due to privacy concerns and lack of consistent data standards. There are also huge data gaps with lack of surveillance of most wildlife and environmental sectors. There can be conflicts of interest where agriculture, pharmaceutical or other industries work against the public interest by preventing research or collection of data. And there is the challenge of how do you measure the success of a One Health approach? There is no agreed metric. So given all of these challenges, how do we implement a One Health approach? We start by building collaboration between sectors, create forums where the health, animal and environment sectors can share their work, research and findings, identify issues that can be worked on together and leverage these. For example, when I was the Chief Veterinary Officer of Australia, the Chief Medical Officer approached me and suggested that I join an expert group that he had formed to work on antimicrobial resistance. I joined the group and then brought more animal health expertise into the group, and we developed the National Action Plan for Antimicrobial Resistance. When it came time to develop the second edition of the plan, we expanded the group again, including environmental science and waste management expertise. We can create incentives and reward collaboration, whether in government policy or in research. If we want people from different sectors to work together for a better outcome, then we need to provide incentives and reward them when they do. At the moment, much research funding is provided within streams, and established researchers are rewarded for continuing to research within their stream. But it is possible to change the incentives and to reward researchers who work with other sectors. We need to improve public awareness. Once explained, the concept of One Health is not difficult to understand. And soon you will have concerned citizens and the general public amplifying the message. Integrated surveillance systems are needed. They need funding and support. There is a tendency to think that surveillance is free or cheap or easy. It is not, particularly in the farm and environment sectors. If we are undertaking surveillance in the interests of public health, then it should be paid for by that sector or out of a common fund. If we want low and middle income countries to undertake surveillance, we need to financially support and equip them. The bigger challenge is achieving policy alignment at the national and international level. One Health principles should be applied so that legislation and regulation recognises the reality of the One Health world. As legislation is drafted or reviewed, it should be assessed against these principles so that systemic change can take place. Let's look at some examples. Climate change is a complex issue with real One Health consequences. As temperatures rise, species are placed under stress, livestock lose productivity, insect vectors of disease have new and larger territories. As climate change is a present and growing threat, we need to integrate climate change mitigation and resilience into our One Health plans. So our policies need to acknowledge that the climate is warming and having these impacts upon human, animal and environmental health. We can seek to mitigate the pace of these changes by reducing drivers of climate change. That might be reducing carbon dioxide and methane emissions. At the same time, we can seek to build resilience through understanding climate change risk, adopting adaptations and strengthening existing ecosystems. How do we implement climate change mitigation and resilience? Through cross-sector collaborations, we share our experience with other sectors, public with private, animal with human, with environment. We collect and share data, we identify what works and collaborate on solutions. Climate change drives traumatic events such as cyclones, typhoons, flooding, wildfires. A One Health approach allows us to build enhanced preparedness for these notable events and adaptation for the daily toll of climate change. Another example is combating infectious diseases. We know that about 75% of new and emerging diseases come from animals, and more than 70% of those come from wild animals. Examples include Ebola and Marburg diseases, pig and avian influenza, monkeypox and MERS, and of course COVID. That is why the One Health approach is so important. Again, conducting surveillance and sharing data is vital. Unfortunately, the first recognition that we have a problem is often detection of disease in humans. But in retrospect, it is apparent that there was disease in wildlife first, and there were interactions with humans that created an exposure and an opportunity for spillover. So we need multi-agency disease surveillance programs that are out there looking, and we need real-time sharing of data so that when disease is emerging and it is recognised and dealt with early. Hopefully, one day we'll get to the point of being able to predict when disease might move due to changes in the environment, such as through clearing forest or climate change. The outcome we are looking for is prevention, rapid response, and containment. If we can prevent spillover, we should. If we cannot, we should ensure we detect it early and are able to quickly contain any outbreak through quarantine, vaccination, and movement restrictions. Strong national surveillance systems protect us all in a globally connected world if we are willing to share the data. Pathogen surveillance is essential for early detection, risk assessment, preparedness, and the effective management of zoonotic diseases and pandemic threats, and is a critical component of global efforts to safeguard public health and prevent the escalation of various infectious disease outbreaks. The limitations of existing surveillance systems have been exposed, particularly when dealing with novel pathogens or pathogens whose geographic range has extended into a new region. Factors including increased travel, trade, intensive farming practices, and climate change may amplify risks associated with the emergence of various pathogens in animals, in humans and animals. It is particularly true of zoonotic pathogens and the potential for humans to come into direct contact with these organisms from various sources. The primary tenet of the One Health concept is that it recognises the health of people is closely connected to the health of animals and our shared wider environment. A third example is ensuring food security. How do we go about ensuring food security? We have a growing global population, particularly in Africa. We also have a much more affluent global population that demands animal protein. How can we meet that need in a sustainable way? Sustainable agricultural practices seek to ensure that we meet our needs this year without endangering our ability to meet them again next year. Can we meet our nutritional needs without destroying the soil that produces our food and feed? Can we have agriculture and a natural environment too? We can. We have learnt a lot about sustainable agricultural practices, so farmers need to be educated and supported to adopt these. Veterinarians can play a role as trusted advisors and models of awareness. It's possible to improve food security. Our farms can be more productive without forever encroaching upon their natural environment. Veterinarians have a role in supporting both food security and food safety. I encourage you to attend the World Veterinary Association Congress being held in July in Washington, DC, which will focus on One Health and the veterinary contribution to food security that John mentioned. So we've had 3 examples of climate change, of infectious diseases, and of food security. For climate change and its impacts on health, we try to mitigate the drivers of climate change and build resilience. We share our experience with other sectors, and we build collaborations to draw upon in response. For infectious diseases to emerging and re-emerging threats, we know where the diseases are coming from, so we need to be alert and conducting active surveillance. We need to share data, and we need to position ourselves to prevent, respond, and contain emerging diseases. And for food security, balancing the demand and sustainability, demand is projected to continue to rise. We can farm productively and sustainably, and veterinarians have a role in food security and food safety. This might be a good point at which to draw attention to the Surveillance and Information Sharing Operational Tool, SISOT, that has been developed by the tripartite organisations, FAO, World Health Organization and the World Organization for Animal Health, and technical experts to support national authorities to establish or strengthen their coordinated multi-sectoral surveillance and information sharing for zoonotic diseases. Such a system is essential for early detection of disease events and timely, routine data sharing among all relevant sectors to support coordinated response, prevention and mitigation of these events. While it provides step-by-step guidance in how to conduct such surveillance and information sharing, it also can be used as a benchmark and a tool to build upon the capacity that exists. One Health solutions. In the preceding example, you will have noted some common themes. We cannot address these complex, cross-cutting issues unless we work across sectors. That is, we need to work in an inter or a transdisciplinary approach. These interdisciplinary approaches in turn require integrated policy frameworks. The policy and operational environment has to support and encourage working across boundaries. If these policies are to be truly implemented, there needs to be community engagement and education. Veterinarians can play a role here as they are able to speak about animal health, understand human health, and the role of the environment in both of these. Likewise, there are roles for farmers, educators, and politicians. The One Health high-level expert panel have suggested that the following is required to implement a One Health surveillance at the national level. There needs to be a national high-level lead. This leader needs not be a technical expert. They provide leadership, strategic direction, and advocacy for the One Health surveillance system. The high-level leader should act as an interjurisdictional liaison, both nationally and internationally, and be responsible for the governance of the high-level expert panel. Communication with the public, policy and decision makers and the international community is a key role of the high-level leader, including communication and reporting of surveillance findings. Secondly, there needs to be a high-level expert panel who are responsible for implementing the surveillance system, providing advice to the high-level lead, responding to key results that emerge from surveillance. In Germany, for example, the Federal Ministry for Economic Cooperation and Development have established a One Health Advisory Board. And then operationally, there needs to be an operational team that works cross-sectorally and thus needs authority and funding to allow it to operate without politicisation. In the paper from the One Health high-level expert panel, they suggest that the operational team could be placed in a separate One Health department, but I'm not sure that this is the best solution, as it then makes One Health their problem rather than something that we all have an interest in. The operational team are also responsible for community engagement, and so they need the skills more social than technical to do this. This paper from the One Health high-level expert panel also recognises that there's an array of skills that are required to successfully establish a One Health surveillance system: legal and ethical expertise, data management and data analytics, laboratory and bioinformatics expertise, social sciences and economics, clinical, public health expertise, animal health expertise, and environmental expertise. So what can we do at the local community level to support the global One Health efforts? Antimicrobial resistance is a global health priority. The antimicrobials we use to treat infections in humans and animals are becoming less effective due to the microbes becoming resistant. Often the same microbes infect humans and animals, and the same drugs are used to try and treat those infections, and both those drugs and microbes are present in the environment, allowing resistance to build up. Local communities can help address AMR. In some communities, pharmaceuticals are manufactured and the waste is allowed to enter freshwater streams, contaminating the environment. In other communities, fish are grown under pig pens to consume their waste, and their health is maintained by prolific use of antibiotics. Local communities can work to stop these practices. Recently, I've been reading of community-based actions in Africa. In one case, education and awareness on animal health and plant production were held in villages, allowing much greater participation, particularly of women. It also allowed the issues being faced by farmers to be seen by the external experts. In another case, farmers were educated on hygienic milking techniques and hygienic equipment maintenance, and this reduced mastitis, and therefore there was reduced use of antibiotics in cattle. In another community, rabies vaccination of dogs was offered with helminth parasite treatment of humans. This allowed two problems to be treated at once, saving much time and expense and allowing community education on these diseases. Perhaps the most difficult aspect of One Health to grapple with is environmental health. How do we assess environmental health? What can we do to improve it? Perhaps the biggest step that can be taken is to restore or introduce diversity into the environment. Even in the urban environment, if we introduce trees, there are numerous benefits with better mental health, reduced summer temperatures, and cleaner air. In one of the most productive areas to look at is waterways. I used to live in Seoul in South Korea. There's a stream that runs through the centre of the city that was enclosed and paved over to facilitate traffic. Now it's been opened up and is full of life with many varieties of fish and has become a real asset to the city, drawing workers out of their offices and tourists to visit. We have seen with climate change that there is widespread erosion of beaches, and as sea levels rise and storms increase in intensity. Some places are recognising that they need to plant mangroves that stabilise shorelines, slowing water flow and providing a safe nursery environment for fish. These community-level initiatives have benefits both locally and globally. We spoke earlier of the need to have good surveillance programs to underpin One Health initiatives and implementation. These need to cover human, animal and environmental health, and the data from these needs to be shared between sectors. Unfortunately, surveillance is not free. It is abundant in the human health sector, but harder to come by in the animal health sector and rarer still in environmental health. Also, surveillance needs to be weighted towards areas of greater risk in order to detect outbreaks early. This means that surveillance is often required in countries and regions that can least afford it, where farming, the natural environment and humans are in close proximity and abundance. If we want surveillance of animal agriculture and the natural environment in low and middle income countries for the benefit of human health in high income countries, we need to be willing to pay for it. This was done in the USAID Emerging Pandemic Threats Program, PREDICT, which focused efforts on strengthening zoonotic virus surveillance and laboratory capacity in hotspot areas. Crucially, resources such as trained personnel, equipment, infrastructure and internet access are all vital to achieving a functioning laboratory system. This is notably challenging in less developed countries, and therefore sharing of these resources across boundaries is to be encouraged as a means to achieving regional and global surveillance, and importantly, countries lacking these resources themselves can still receive the surveillance data. There are some very worthy programs. The WHO Tricycle Protocol, which uses a standardised methodology to conduct surveillance for antimicrobial resistance in human, food chain and environmental sectors, focusing on extended spectrum beta-lactamase E. coli as an indicator organism. The COVID-19 pandemic highlighted the need for a framework of pathogen surveillance to allow timely detection and response to health threats. It also demonstrated the value of wastewater surveillance, as a wastewater contains both pathogens and chemicals, and one sample of wastewater can be analysed for chemical residues, for antimicrobial residues, for genes, for pathogens and for genetic analysis. Surveillance generates data, and big data frameworks such as metagenomics enable disease surveillance methods, enable detection of known and emerging pathogens. Wastewater-based surveillance is an existing technology. It was used decades ago to demonstrate the presence of poliovirus in urban sewerage. Wastewater-based surveillance can provide a cheap and less invasive alternative to traditional disease surveillance approaches for certain human diseases. It allows for easy sampling for a range of environments, and each sample can then be subject to multiple tests for chemicals, for pathogens, and for genetic markers, as we saw in the student presentations earlier today. On the 21st of March in 2022, the four international agencies, FAO, WHO, WOAH and UNEP, signed a landmark agreement to strengthen cooperation to sustainably balance and optimise the health of humans, animals, plants and the environment. And the One Health high-level expert panel have written a paper on developing a One Health surveillance system, and they identify 6 steps. The first step is to develop a surveillance system scope and to develop and agree upon the scope. The second is to define data collection components and to agree on sharing the data and the data that emerges from that surveillance system. The third is to draft an overarching organisational plan that will incorporate the surveillance system, and it must allow for flexibility so that as the environment changes, if there's an environmental disaster such as a hurricane or a wildfire, that the plan can accommodate that. The fourth step is to define the governance system, bearing in mind political, ethical, administrative, regulatory and legal barriers and enablers. The fifth step is to develop protocols for managing the surveillance. So this is to plan in advance and to conduct exercises. What will happen if you detect an emerging disease? And the final step is to develop a joint roadmap for implementation of the surveillance system, bearing in mind that it may be developed with different speeds and priorities. So in conclusion, One Health is a powerful framework for addressing complex issues such as emerging disease, but it is only useful if it is implemented. This will require investment in building surveillance systems, in establishing cross-sectoral teams, and in active collaboration. We face many global challenges, including climate change, food insecurity, and infectious diseases. One Health provides a framework for a sustainable future. And there is a role for all of us. Yes, there are global initiatives and agreements, but local communities can make meaningful changes to their local environment that have broader impacts. There are many obstacles to adopting a One Health approach, as we are rooted in old and current ways of doing things and thinking, But if we deliberately collaborate and build public awareness, a momentum can be established. Whether it is a traumatic climate-related event or an outbreak of infectious disease, we want to be able to respond comprehensively, quickly and sustainably. Strong surveillance systems are the best investment, and coming out of the COVID experience, we can see that surveillance systems can be very powerful and informative. Veterinarians have a role in all of this, whether it is the issue of food security or emerging infectious diseases, but we are not there alone. We are part of a One Health team that includes social scientists and expertise in economics, lawyers, ethics, data, bioinformatics, and laboratory expertise. Wastewater sampling is one surveillance method that can be efficient and cost-effective, but nations should be working towards establishing One Health surveillance systems, and the One Health high-level expert panel has provided guidance on one way of doing that, to consider the scope, the data requirements, the system design, the system's governance, its response protocols, and its implementation. Ultimately, it comes down to implementing One Health rather than just talking about it. And the first step is collaboration. Thank you.
Dr. Mark Schipp, thank you very much for your nice presentation. And I got a couple of questions from the website. So this morning, you heard the presentation from the high school, in Japanese high school, and then regarding these issues in Japanese, 気候変動、感染症、
climate change, infections and security in Australia and in the rest of the world on the citizens level or on the student level. Are there any implementation practices that you can show us as an example? We'd like to know how the Fukuoka initiative by the students are different. We'd like to know some of the examples from overseas about implementations.
Yes, I think there is much that can be done at the community level. I was very impressed with the presentations from the students this morning. But as I said in my presentation, one of the gaps, one of the challenges we have is that diseases are going to emerge from wildlife, and we have little exposure to wildlife. If we can increase our awareness of wildlife to be alert to if there are sick or dead animals in the wild, that will be an early indication of a spillover event. In Australia, we have established Wildlife Health Australia, which is a non-government, non-profit organisation that brings together all of those with an interest in wildlife, including veterinarians, zoos and the public. And it builds up a surveillance framework so that every year we get a lot of information about wildlife disease, and that provides us with forewarning of disease that might spill over into humans or into livestock. And I think if we can put more effort into looking at events in wildlife, that will be most beneficial. But in terms of direct action by the community and by students, I thought what we saw this morning was excellent, and any efforts that can be taken to increase the biodiversity and the resilience of the natural environment are to be applauded.
Okay, thank you. And また増えてきましたので、もう一つ。
Perhaps I want to ask one more question. I'm receiving more and more questions. Well, perhaps you have been involved in One Health initiative for a long time.
Question, could you accept? Okay. Businessの分。
Well, in business, private companies and universities, there may be platform being formed for a collaboration. And then for One Health, multiple just research institutions and the government agencies and others. Do you have such kind of a platform to promote these kind of collaborations in Australia or any other place in the world?
No, I had not seen private sector collaboration previously before I came to Fukuoka. The way that you've been able to integrate One Health with the private sector, with the farming sector, the use of the logo, the streaming into schools is very impressive and to my mind is world leading. I think you should be amplifying your message and your approach not only within Japan but beyond because the example that you have is outstanding.
Okay, thank you very much. Actually, I'm very interested in the paper published in Nature Communication, and Hill et al. Reported a case study. So, and then finally, in the conclusion, you said, let's start a collaboration. So, if we can do something like surveillance, so can I collaborate with you?
I think the collaboration between sectors, and you're a dental, you're from the dental sector.
Yeah.
With the human health sector, with the veterinary sector, with the environment sector, but it needs to be beyond that. We need expertise in economics and social science and law. So all of that needs to be brought together to make the collaboration truly effective and powerful. As I said in my presentation, collaboration beyond borders can be sensitive. Some countries are very adverse about sharing surveillance of human health or animal health because they realise it will have an impact on trade, on tourism. And so we need to find a way to create a safe space, a community of practice and collaboration. And I think that sharing at the technical level avoids some of the political problems. If we can share at the technical level and build that trust, then we create a strong foundation for future collaboration.
Actually, in this forum, finally, we talked about the new center is a One Health Center in Fukuoka Prefecture. I hope we will collaborate. Thank you, sir. Thank you so much.
I look forward to that. Thank you.
Mr. Nishihara to moderate the session. Now, I'd like to introduce the next presenter, Dr. Maria Minerva, Calimag. Dr. Calimag has been a professor of pharmacology and clinical epidemiology at the Faculty of Medicine and Surgery of St. Thomas University since 1986. She also served as president of Philippine Medical Association, the Philippine Society of Anesthesiologists, and the Philippine Society of Experimental and Clinical Pharmacology. In 2024, she was appointed president of the Confederation of Medical Associations of Asia and Oceania, CMAAO, and they signed a MOU with FAVA for cooperation in One Health initiative. Today she will speak on antimicrobial resistance, a shared challenge for physicians and veterinarians in the food cycle. Dr. Calimag, the floor is yours.
Presentation. Thank you.
So, konnichiwa. So it is good that we started big. We had the World Veterinary Association speak, and then, of course, the One Health by Mark Schipp, and, of course, Jong. And now we're going to much smaller part, which is our issue on antimicrobial resistance. And for this, I entitled it A Shared Challenge for Physicians and Veterinarians in the Food Cycle. So we had two veterinarians address the forum first, and I am a medical doctor, past president of the Philippine Medical Association, and now president of the Confederation of Medical Associations in Asia and Oceania, Australia included. So we had this signing of the Memorandum of Agreement last August 24, 2024, in Manila, when I was installed as president during the 38th General Assembly and 59th Council meeting of CIMAO. And now I meet again Dr. Karauchi. I was surprised because when I was in the plane coming to Fukuoka, he came to me and said, "Welcome to Japan." So we were together on the plane coming. He was coming from Davao, actually, to speak before veterinarians. So One Health, Fukuoka, FABA. Now let me just start with disciplinarities and defining disciplinarities, because when you talk about intradisciplinary, cross-disciplinary, multidisciplinary, there are different ways of looking at it. Many of the articles in journals about One Health talks about One Health as interdisciplinary, meaning integrating knowledge and methods from different disciplines, using a real synthesis of approaches. However, I would like to propose the word transdisciplinary, because we're actually creating a unity of intellectual frameworks. We want the frameworks to work both for the veterinarians as well as for patients, human health. So this is beyond the disciplinary perspectives already. So Dr. Nishiwara, we will be also joined in by the dentists. So when do we need transdisciplinarity? This is actually one where we address the societal discourse. We want policies to actually address our problems, and we don't just want joint field work or development of integrative conceptual frameworks and methodologies, but we want a regular exchange of knowledge and identification of collective action. And that's the reason why I requested that if it is possible that our presentations now will become part of the Japan Medical Association Journal, so that it will reach more physicians. So when we talk about antimicrobials, they are important medications. It would be difficult to, of course, overstate the significance of penicillin, introduced sometime in the 1940s. But antibiotics, while they're used to treat bacterial infections, we talk about antimicrobials because we talk about treating infections caused by parasites, viruses, and fungi. So when we talk about antimicrobial resistance, it poses a significant threat to global health. And this lecture explores the interconnected roles of physicians and veterinarians in addressing AMR within the food cycle, emphasizing the One Health approach. If you have a chance to download the World Medical Association Journal, you'll see that I've had parts of a transdisciplinary papers on vaccination, on antimicrobial resistance, and also on national security, food security. So as antimicrobials are widely used in both medicine and agriculture, Their overuse and misuse have accelerated the development of resistant strains. We said that, of course, we need to address climate change. We need to address environmental health. You might want to look at my paper on research and the social agenda, The Tale of Two Rivers, of Dead Rivers and the River of Life, because it's all really about planetary health, human health, and One Health. So physicians and veterinarians are at the front line of combating AMR by ensuring prudent antimicrobial stewardship and thereby safeguarding public health. We will know how to have insights on resistant pathogens and how they're transferred from animals to humans through the food supply chain. And this will cover current regulations, surveillance strategies, and innovative practices aimed at reducing antimicrobial usage in agriculture. So it will impact how it will impact AMR on clinical outcomes in human health, animal welfare, and food safety by fostering a shared understanding and approach. So we cannot understate the importance of education about antimicrobials. If you will look at here, out of 235 million doses consumed annually in the United States, out of 40 million people who are given antibiotics for respiratory issues, over 27 million people get antibiotics unnecessarily. There's overprescription. And only 13 million people who really need it actually get them. So there's a large proportion also of people who are supposed to get the antibiotics but don't. So they are the ones who get sick. No? And of course, we want to show that we have to have in our hospitals antibiograms, no? That is of course predictive of subsequent antibiotic susceptibility. And therefore, it will be a crucial part of appropriate antibiotic selection for a given patient. So this is a picture of AMR worldwide. And here in Asia, no, the burden of disease of tuberculosis has been there since 1903. Now it's 2025, and we have this Stop TB partnership across all of Asia and all of the world, because still 480,000 people are infected by not just drug-resistant TB, but multi-drug resistant, no, and extremely drug-resistant TB. So 25,000 patients at least die a year out of antibiotic-resistant infections. So the numbers are there, no? They say that visuals, no, say more than what we can say, no, in words. So this is the antibiotic resistance or the antimicrobial resistance timeline. If you will notice, penicillin was introduced in 1943 after penicillin R staphylococcus was discovered in 1940. And the penicillin R pneumococcus and resistance came in 1965. So that is almost 20 plus years. But if you look down at ceftazidime, the antibiotic was in 1985. The resistant strain came out 1987, just 2 years. No? And ceftriaxone, no? In 2010, you already have the resistant strain in 2011. So the time, no, to develop this resistant strain is getting shorter and shorter. So estimated minimum number of illnesses and deaths caused by antibiotic resistance, at least 2,049,000 plus, and 23,000 deaths. If we look at Clostridium difficile, 250,000 illnesses and 14,000 deaths. So by 2050, if AMR is not tackled now, at least one person could die every 3 seconds, not minutes. So in 2015, the World Health Organization survey found that 76% of respondents thought that antibiotic resistance referred to the human body's resistance to the drug rather than the bacteria's resistance to the drug. And therefore, they try to advance the term drug-resistant infection and drug-resistant bacteria to be more precise. So medication-resistant infections, of course, cause more serious illness, longer recovery, more frequent hospitalization, more doctor visits, and more expensive treatments. So antibiotics don't work for everything, no? So colds, we say, drink lots of water, hydrate. So misuse of antibiotics, of course, can include any of the following: when they are prescribed unnecessarily, when they are delayed in critically ill patients, they're given too generously, or when narrow-spectrum antibiotics are used incorrectly. Some people say, it's a 500 milligram drug. Maybe I should only get once a day, or maybe for just 3 days. Anyway, my symptoms are gone. No? So we have to tell our patients that you have to take it for every three times a day for 7 days. No? So when the treatment is either too short or too long, you can have problems with resistance. Then when antibiotic is not streamlined according to microbiological data, not according to the antibiogram of your hospital, then you can also have misuse of antibiotics. So any bacterium that survives an antibiotic or an antimicrobial treatment can multiply and pass on its resistant properties. Now let us look at how antimicrobial resistance develops in the bacteria. So you can have limiting uptake of a drug by impermeability because of modification of the cell wall protein, modification of a drug target, inactivation of a drug by enzymes, and of course, increasing active efflux of the drug by pumping out. So, and here are some of the families of efflux pumps out there. So you have the ATP binding cassette, so on and so forth. Now, here are the antibiotic targets. Of course, the cell wall, that's the penicillins, the beta-lactams, and the vancomycin, and the DNA-RNA synthesis, antibiotics, fluoroquinolones, and rifampicins, folate synthesis, trimethoprim sulfamethoxazole, cell membrane, daptomycin, and protein synthesis. Now, when we talk about antibiotic resistance, then we have the different antibiotics that are affected by efflux, immunity and bypass, target modification, and the inactivating enzymes. So there's a lot. Now, deaths, you will see that in Africa and in Asia, you have almost the same number of deaths, as can be shown by the big circles. Now, for hazard level, they can either be urgent, serious, or concerning. Now, here, Clostridium difficile, Enterobacteriaceae, and Neisseria gonorrhea, the hazard level is urgent. We have to stop this bacteria from propagating. And here are 12 antibiotic resistant microorganisms that have serious hazard levels. And another 3 with concerning hazard level, including vancomycin-resistant Staphylococcus aureus. Before we say, if you have a MRSA, give vancomycin. Now, vancomycin-resistant Staphylococcus aureus are already there, the clindamycin and the erythromycin-resistant and microbes. So they say that superbugs are a bigger risk than cancer. Yes, because you cannot pass on cancer except vertically, no? But of course, superbugs, no, can be transmitted horizontally, no? And of course, for HIV, no, even vertically. So in human medicine, antimicrobial stewardship refers to the coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting selection of the optimal antimicrobial drug regimen and route of administration. So when we talk about antibiotic stewardship in our hospitals, you can decrease resistance, decrease transmission of bugs, no, that are like Clostridium difficile, and of course decrease cost with increased patient outcomes. Okay? So we ensure that all orders have dose, duration, and indications that are necessary, and we take an antibiotic timeout, no, where we reassess antibiotics after 48 to 72 hours. So we don't just give antibiotics left and right. So a University of Maryland study showed that one antibiotic stewardship program saved a total of $17 million over 8 years. And antibiotic stewardship helps improve patient care and shorter hospital stay. But of course, it's very simple to prevent transfer. We wash our hands before touching a patient, clean and aseptic procedure, after body fluid exposure, after touching a patient, and after touching a patient's surroundings. So the 4 moments of antibiotic decision making. In surgery, we have these 4 questions also. Before doing surgery, are we doing it for the right patient? Who are doing it? No. Now this time, 4 moments for antibiotic decision making. Does my patient have an infection that actually requires antibiotics? Have I ordered appropriate cultures before starting antibiotics? What empiric therapy should I initiate? A day or more has passed, no, after empiric treatment. Do we stop the antibiotics? Can I narrow therapy or change from IV to oral therapy? This is significant, no? Because sometimes we look at the antibiogram, the drug that we have given empirically does not work, we still continue on with the treatment, no? So we have to change based on the culture and sensitivity. And what duration of antibiotic therapy is needed for my patient's diagnosis? Because sometimes we have urinary tract infections, kidney infections that need more than 7 days, usually 14 days. No? So many decision support programs have been developed during the past few years. There are apps actually that are emerging. It will tell you what drugs don't work together, and it can also assist us, no, in antimicrobial stewardship. So how does antibiotic resistance spread? No? So here we see that it crosses, no, from the animals we eat, the antibiotics they get, the resistant bacteria that develop in their systems, and it crosses over to us, no, humans. So 1 out of 5 resistant infections are actually caused by germs from food and animals, no? Almost 409,000 illnesses each year. So all animals carry bacteria in their intestines. Giving antibiotics to animals will kill most bacteria, but then resistant bacteria can survive and multiply. And 3 potential mechanisms are direct infection with resistant bacteria from animal source, breaches in the species barrier, followed by sustained transmission in humans, arising in livestock, transfer of resistance genes from agriculture into human pathogens. So this is One Health, humans, animals, and the environment. Just as Dr. Jong and Dr. Schipp has told us. We have a One Health approach to tackling AMR, as bacteria-carrying resistance genes are present in and spread between people, animals, food, and the environment. The One Medicine by Calvin Suarez has its origin in his work with pastoralists in Sudan in 1960. He said that there's no difference of paradigm between human and veterinary medicine. Both sciences share a common body of knowledge in anatomy, physiology, pathology, on the origins of diseases in all species. And I agree with him. During my pre-med course, we were studying animals, no? And how parasites are transferred. No? So even before, we should have thought about One Health. So Robert Virchow, between animal and human medicine, there is no dividing line. Veterinary epidemiologist and parasitologist, again, Dr. Calvin Suarez said, One Medicine is a unified human and veterinary approach to zoonotic diseases in his 1964 book, Veterinary Medicine and Human Health. So the American Veterinary Association defines One Health as collaborative effort of multiple disciplines working locally, nationally, and globally. So the word multiple there might, imply multidisciplinary, but as I've said, no, it should be transdisciplinary. We know, so the World Health Organization supports the optimization of the use of antimicrobial medicines in human and animals to preserve their effectiveness by taking a One Health approach. So, 4 key resistance levels in 4 key bacteria in animals, in humans, and in retail meat. No? So 2/3 of global consumption of antibiotics is actually in livestock production. This is the global distribution of animal biomass. No? Estimated coverage in Africa, the red one, no? And those that are not covered, so you have there the looks different on that slide. And then global distribution for Africa, you have 50%, 50-50, no? Of covered and those that are not covered, no? In the Americas, it's a 77-23 ratio. So globally, it's actually 1 to 1/3, no? 1 to 2/3, 1/3 and 2/3, 35-65. So species consumption of animal biomass, the bigger part, 41% are for the bovines, no? Cattles, and then 21% for swines, pigs, no? And poultry. For the 8th report of the World Organization for Animal Health, Dr. Schipp, annual report on antimicrobial agents intended for use in animals, look at tetracycline, no? 35.63%. No? So reportedly, so you would expect more resistance to tetracyclines. No? And for the terrestrial food-producing animals, no, included in quantitative data, again, more of cattle and poultry and the small ruminants. So proportion of antimicrobial classes by terrestrial food-producing animals, no? You'll see that, again, tetracycline is the most used. For aquatic, mostly fish, And then, of course, you have the crustaceans, the amphibians, and the mollusks. This time, the amphenicols, chloramphenicols, are the biggest share at 48.31%. The tetracyclines still a close third. So you have the reference there. For the non-food producing animals, this includes the canines, felines, the cats, and the ornamental fish. Proportion of antimicrobial classes by aquatic food-producing animals, the greater proportion are among the penicillins, followed by the fluoroquinolones, and again, tetracycline is third. As to route of administration, the proportion of antimicrobial quantities, aggregated class data, So you have here a big proportion are the quinolones, the arsenicals, So antimicrobial susceptibility profile of E. coli isolates in Ethiopia. So you have there your variable degrees tested from cattle. 58.6% are resistant to sulfamethoxazole trimethoprim. 55.7% are resistant to sulfoxazole. And 54.3% resistant to cephalotin, and 45.7% are resistant to tetracyclines. Oops. For the dairy cattle, from humans who are in contact with the dairy cattle, show the high proportion of resistance to amoxicillin clavulanic acid, 70%, ampicillin, 66.7%, resistance to sulfamethoxazole trimethoprim, streptomycin, tetracycline, and ciprofloxacin were observed in 63.1%, and so on down the line. So you will see that humans who are in contact with the dairy cattle with also show high proportion of resistance to the antibiotics. In Uganda, resistance mostly from tetracycline, sulfamethoxazole, and trimethoprim. For poultry isolates in Bangladesh, 100% for tetracycline, sulfamethoxazole and trimethoprim again. So here is a map of AMRs in our livestock. So what is the burden of AMR in animals? This is from the Annual Review of Public Health on external societal costs of AMRs in humans attributable to antimicrobial use in livestock. And of course, you see there that they can either be foodborne, from manure, from the environment, or it's either through occupational hazard. These are some of the foodborne bacteria carried by animals: Salmonella, Campylobacter, Shigella, and of course, Listeria. So we cannot regulate everything. We have policies, but we cannot really reduce all antimicrobial utilization and antimicrobial resistance. It is not enough. We have to train people to reduce, and therefore we look at capacity building, and we congratulate One Health clubs in high schools, here in Fukuoka. Thank you very much. Yes? The young children, we should start them young so that they can become veterinarians, they can become MDs, and when they do become one, they will be able to make sure that everything is secure from the food we eat, and from intensifying the healthcare system as a whole. That is important, no? And of course, we need to have voices like Dr. Jong, Dr. Schipp, myself, on the other side of the fence. So I make sure that the CMAO president, the Confederation of Medical Association of Asia and Oceania, will be loud and proud to promote One Health. So we have to change our practices. It can be a carrot and stick, no? What are the incentives for change? It can be formal, through regulation, through modernization, but they can also be informal, dispersed, rural, no? Based on traditions. Back in the Philippines, out of 119 million Filipinos, 14 to 17 million come from indigenous communities. And therefore, we launched this Reaching the Unreached flagship program so that we can go to them, communicate with them. We are there speaking 187 different Philippine-based languages. No? So we have interpreters going to them, teaching them, no? How to do things, how to make sure that they are healthy. No? So this is crossing tradition and culture. So when do farmers adopt new behaviors? You know what? There are indigenous communities from Mindanao. We call them the Badjaus. They live on the sea, on houses with stilts, but they're being pushed to the urban areas in Batangas. So from indigenous communities, they have become urban poor. And in Batangas, they don't have water. So when we tried to reach out to them, we gave them deep well pumps. No? Imagine, people who are used to living surrounded by sea, no? Now lives in land with no water. So we have to make high effort, no? Required. Teach where there is lack of knowledge so that we don't need those motivators, especially fear and law, no? But we make everything simple, no? We teach them how to be stewards of the environment. So for livestock, before touching, before clean and aseptic procedure, after body fluid exposure, after touching livestock and touching livestock surroundings, we do hand washing. Hand wash. So here, of course, last but not the least, no, vaccination. So we vaccinate our livestock to protect them against diseases, inhibit disease transmission, food safety, resource efficiency. Just the same way we try to communicate vaccination for humans. No? There's been much vaccine hesitancy since the pandemic began because everybody's saying, we're saying that RNA, DNA vaccines are not vaccines. No? So only time will tell. But if it were not for the vaccines, we will not be here today. We will not be communicating with each other face to face. So thank you very much for your attention. I'm so happy to be here in Fukuoka. Thank you so much for all of the people who made these things possible. You know who you are. It's very difficult to say Japanese names, but I will always remember you in the pictures that we take together. Thank you very much.
Calimag, thank you so much for your nice lecture. And then I got some question, and one is in Japanese. Japanese language. One Health 活動に
And One Health activities, One Health initiatives in agriculture producers and also the veterinarians and the doctors. These trinity relationship collaboration is necessary. In order to make those collaboration smooth, what would be necessary? This is one question raised by some of the people. So in order to make a smooth operation, what will be necessary?
The pandemic has actually made things easier for us. While we love crossing borders, riding planes, there is the webinars. No, we have webinars that we can actually communicate and preach the gospel, so to speak. So that is one thing we can do, and then we can, of course, ask the World Veterinary Association to speak among us physicians too. Okay? So those are things. Capacity building, education is the best.
Okay, and I think this question is suitable for the general discussion later. Okay. Next one is specific question is antibiotics. So, 日本において
In Japan, ESBL producing, this is a beta lactase producing bacteria are seen one way or the other. This is because of the broad spectrum long-term antibiotics use. How is this tackled globally, mostly in Asia? That's the question.
Well, again, education is important because now in the hospitals we have the antibiograms. If the antibiogram says that this particular bacteria is resistant, no, we refrain from using that antibiotic. No? So that will lessen the burden of, like for example, the beta-lactamase resistant bacteria, because they work by an enzyme, no? The enzyme beta-lactamase. So by giving those holidays, no, antibiotic holidays, no, then we can reduce the burden of those resistant bacteria.
That means
like in our hospital, for example, no, if any physician orders an antibiotic,
okay,
there is a team of infectious disease specialists who will try to scrutinize the prescription. So that is one way. No?
Regarding antibiotics, and then one more question is Bangladesh no
In Bangladesh, AMR data of Bangladesh via birds, the tetracycline resistance 100% from bird. Still, tetracycline is being continued to be used.
This question is concern regarding your data today.
Yeah.
Data.
It's a pity that I was not able to ask the physicians from Bangladesh. I was there two years ago. And the CMAO was in Bangladesh 2 years ago, before the skirmish that they're having now. Yes, perhaps if I give this lecture to CMAO, now Bangladesh will hear, and then they will have to give a holiday for tetracycline. But if you will notice, in Ethiopia, in Uganda, not just Bangladesh, no, almost all areas, tetracycline resistance is very high because it's very affordable. It's very affordable. So if they say, you need an antibiotic, okay, give tetracycline. Of course, we don't use it especially for babies, no, because they develop this tetracycline teeth. right? So, so we're aware of that. But then for livestock, they give it because it's very cheap.
That means your data means there are very big discrepancy among the Asian countries. That's right?
Yeah.
Okay. お国によってやはりいろいろこう事情が
Depending on each country, the situation is different. And the use of antibiotics, according to the data of Dr. Calimag, there are certain discrepancies among Asian countries.
Okay. Thank you for your nice question and answer. And then,
Also, by the way, I said about trimethoprim sulfamethoxazole. It is used mostly for urinary tract infection. And I think the reason why resistance to trimethoprim sulfamethoxazole occurs is because it's given too short, when sometimes it has to be given longer than 7 days. So that's one of the possible reasons. So thank you very much again.
okay, once again.